billing is a necessary part of what we do because our employer has to be able to bill insurance companies and bill payers in order to get the money to pay us. So we want to make sure that we're billing accurately, we're using the appropriate codes, because your billing department in your clinic or hospital where you work can bill an insurance company, but they can deny the charge for any number of different reasons, for not using the right codes or for not doing the billing units right. And so it's something that we're kind of just starting to learn about in school, and you'll hear more and more about it as you go out into the clinic. So I'm just going to do an overview of CPT codes, which are the codes that we use, and billing units, and we're going to keep talking about it during the program. So if you feel in over your head a little bit on this, that's okay. We're just starting out. So CPT codes are codes that are established by the American Medical Association for providers, healthcare providers, to bill for services. So the learning objectives for this presentation are to be able to report the appropriate CPT code for each PT intervention you learn. So in our procedures classes, we're learning new interventions. And so you want to know what is the appropriate CPT code for each of the interventions that we learn. And we also want to be able to accurately record the billing units for each treatment session. So the thing that happens probably more often than not is you do not bill for everything that you do. So we need to accurately record and accurately bill for what we actually do, because you want to get paid for what you're doing. So that was one of the biggest lessons I learned when I was right out of school. Well, right out of school, I worked in an outpatient clinic, and they told us what to bill. They said, bill this, do this, bill this. So that made it easy. But then when I moved into another setting, I moved into a subacute setting. At my first performance review, my manager said, you need to learn how to do your billing better. Need to do it more efficiently. And she gave me a lot of good tips. And one of the things that she said is, you're not billing for everything that you do. So the time that you spend with the patient, you need to make it billable time. You need to make every minute you spend with them skilled therapy and billable time. And that's how you get your productivity numbers higher. And that's how you get paid for what you're doing. So I actually used to walk around with a stopwatch around my neck, and I would time every single thing I did, and I would write every single thing down until I got the hang of it. So that was a very useful experience for me, because I learned how to do the timing on the billing. So it's really important. Now I can wing it a little bit more because I've been doing it for a long time, but the stopwatch was super helpful to start out. So CPT codes are published by the American Medical Association, and they put out updates every now and then. And I think the most recent update was 2018, I want to say. And it's listed at the end of the presentation under references. Throughout the CPT code set, they use terms like physician, qualified healthcare professional, individual, and that's not intended to say that only a physician can report the service. For our purposes, it's the licensed PT or PTA reporting the service. So when they say qualified professional or provider, they're talking about you. So you're the provider of the service. So I'm going to talk about the CPT codes that we'll mostly use in the classes that you have in the program. Not to say that there aren't other CPT codes, there are, but between 97110 and 97140 in that range are usually the ones that we use for therapy. So occupational therapy has a little bit of crossover in that, and then they have other ones that we don't use. So an occupational therapist can bill for vision therapy because that's one of the specific things that they're trained to do, but we can't bill for vision therapy because that's not under our scope of practice. And certainly there are codes for physicians that they can bill for bill for that are under their scope of practice that aren't under ours. So we're just talking about the ones that are relevant to physical therapy. So a therapeutic procedure is a manner of effecting change through the application of clinical skills or services that attempt to improve function. How's that for a definition? That's straight out of the AMA. So the therapist is required to have direct one-on-one patient contact in order to bill for therapeutic procedures. The only one procedure that you can bill for that doesn't require one-on-one contact is group therapy. And I'll talk a little bit about group therapy, but group therapy requires constant attendance, but not one-on-one patient contact, okay? Starting out there. So I'm just going to talk about commonly used codes in PT, and some of these you have encountered in each of your classes. So in your acute care class, therapeutic exercise came up, and some other ones probably. In your modalities class, we're going to talk about a few more, talking about codes for specific modalities. In your neuro-read class, we're going to talk about a few more. So we're kind of adding them on little by little until you get your little galaxy of charges. And I'll talk about just the variations in charging in a few minutes. So 97110 is therapeutic exercise. That code, 1 unit of therapeutic exercise is 15 minutes. So therapeutic exercises are exercises to develop strength and endurance, range of motion, or flexibility in any given body part. So if we do therapeutic exercise, we'll say therapeutic exercise to improve strength and range of motion in the right lower extremity. That's how we're going to write it. And then we're going to say what we did. That was that. So we say the code, why we did it, and what we did. And that's in our treatment section, okay? So 97112, neuromuscular re-education, it's also a 15-minute code. So codes are either 1 unit is 15 minutes, or they're untimed, meaning that if you do that at all, you charge 1 of it, and it's for any amount of time. So an untimed code, if you do it for an hour, you charge 1 unit. Or if you do it for 15 minutes, you charge 1 unit. So some of the evaluation codes, which we don't use as PTAs, are timed different times, and some of them are untimed. But most of the codes we use, besides group therapy, are timed, and a few of the modality codes are untimed. So 15 minutes is the time we're talking about. Neuromuscular re-education is re-education of movement, balance, coordination, kinesthetic sense, posture, and or proprioception for sitting and or standing activities. So if you have someone, you're treating someone with an ankle injury and you're using the BAPS board to retrain their kinesthetic sense and proprioception and balance, you're doing neuromuscular re-education. On a mini trampoline, on a Swiss ball, using the body blade, doing proprioceptive neuromuscular facilitation, doing NDT, or any of the other neuro re-education tools that you will learn more about in your neuro re-ed class. But basically, it's some neurological sense, like posture, balance, coordination, kinesthetic sense, that we developed when we were children, and then we lost it somehow through illness or injury, and then we have to re-educate that neuromuscular re-education. Interesting, right? Aquatic therapy sounds obvious, right? You're doing therapeutic exercise in the water. It has a different code because you're in the water. 97113, it's a 15-minute unit. Gait training, 97116, also 15-minute unit. Gait training includes stair climbing. So you're trying to improve safety, increase independence, you're trying to restore normal gait. All of those things are appropriate for gait training. Lots of different activities are included in gait training. So it's not just walking, it's gait training. It's encompassing lots of different activities. 97140 is manual therapy techniques. So mobilization, manipulation, manual lymphatic drainage, manual traction, 15-minute unit. The type of treatments that we're doing that qualifies manual therapy are soft tissue mobilization, myofascial release, serial compression bandaging for lymphedema, which we'll learn in fall quarter, and joint mobilizations. Those are manual therapy. So it's a lot of the hands-on thing. And so we're going to be doing mobilization to improve joint mobility, or manipulation to improve joint mobility, manual lymphatic drainage to reduce swelling, manual traction to for lots of different reasons, to improve joint mobility or decrease pain or increase flexibility. So we're going to say why we did it. So we're going to say soft tissue mobilization to promote tissue healing through increased circulation. That's a really good reason for doing soft tissue mobilization. So with each of the techniques that we are going to learn, we will talk about why you do it. So the why of why you do it is clinical indications. Why is this treatment indicated? Why are we going to do it? And what are we going to charge for it? So group therapy, okay, this may sound obvious, but the definition of a group is 2 or more individuals, and the therapist doesn't count. So if you only have one person, you cannot charge group therapy. You have to have at least 2 patients and 1 therapist to charge group therapy. That may sound obvious, but some people don't get that. So group therapy procedures involve constant attendance of the therapist, but they don't require one-on-one patient contact by the same therapist. It's an untimed code. So if you do group therapy for an hour, you don't charge 4 units for 15-minute units. You charge 1 because it's an untimed code. So examples of group therapy, it's not what the patients are doing that determines whether or not it's group therapy or one-on-one treatment. It's what the therapist is doing with the patients. So how is the therapist treating the patients? Is the therapist or assistant one-on-one with one patient while the other patients are doing some sort of exercise or intervention independently or under supervision? Or are they in constant attendance of both patients providing a skilled intervention with no measurable amount of direct one-on-one time spent with either patient? So if you're doing one-on-one with one patient, you can't be doing group with the others. You have to be paying attention to all of them on some level. So sort of multitasking. So I'll give you an example. So I have 3 patients. They all had knee replacements. They're all coming in at 9:30 to be in the joint replacement group. They have a list of exercises that they do, and they have pictures and descriptions of all the exercises. And I am monitoring the group and leading the group, basically. So when the patients come in, I say, hi, Bob, Sue, and Lynn. Bob, I'm going to have you on the bike. Lynn, you're going to be on the new step. And Sue, you're also going to be on the other new step. So let's get started. So everybody gets on. I help them adjust the equipment appropriately for them, each person. And then they all start and they do their bike or their new step for 8 or 10 minutes. And then I say, okay, Bob, you're going to be on that table. Sue, you're going to be on that table. And Lynn, you're going to be on that table. And I want you start with this exercise, you start with this exercise, and you start with this exercise. So they start, and as they're working, I might go around and do some corrections, and I might, they ask me a question, I answer a question, and then I help work them through their exercises. I'm not spending any more than 5 minutes one-on-one with any one patient. I'm monitoring and working with the whole group, okay? Here's an example. That's group therapy, and I'm going to charge 1 unit of group therapy for each of those patients, even if they were there for an hour or 90 minutes. Here's another example. Same 3 patients come in, and Bob says, boy, my leg is really swollen today. And I'm like, okay, let's get everyone started. So I get them on their equipment. And then I take Bob over to the mat table and I do 10 minutes of manual lymph drainage while the other 2 are on the bikes. I can charge 1 unit of manual therapy for Bob but I can't charge anything for Lynn and Sue while I'm working one-on-one with Bob, because I'm working one-on-one with Bob. I can't be paying attention to those other two because I'm one-on-one. So, and it has to be one-on-one and group are distinct procedures. You can't be doing them at the same time. So that's kind of the difference between one-on-one versus group therapy. So in a group setting, you're doing no measurable amount of direct one-on-one time spent with any of the patients. You might have a therapy team where one therapist is doing one-on-ones with people and one therapist is doing the group. So I've seen group programs in several different settings: outpatient, inpatient, subacute. And the main commonality between all of those is you're not doing direct one-on-one treatment with any one patient. You're supervising all of them at once. Okay? So you might run into a group therapy program in one of your settings, and it's not what the patients are doing that makes it group. It's how the therapist is treating them that makes it group. So the therapist or assistant is in constant attendance of 2 or more patients, providing skilled therapy and interventions, but not providing any significant amount of measurable one-on-one time to either patient, whether on land or in an aquatic setting. So you can have like a group exercise class in the water, a group aquatic therapy charged under group, but you're not doing one-on-one with any one of those patients. So each patient is billed 1 unit of 97150. Group therapy is a service-based rather than a time-based CPT code. And so you're not, even if they're there for an hour, you're not charging them 4 units. Okay? Therapeutic activities, it's, of course, direct one-on-one patient contact, use of dynamic activities to improve functional performance. So functional is the key here. It's a 15-minute code. So lifting, carrying, pushing, pulling, pinching, grasping, crawling, climbing, lunging, throwing, catching. You can read all those. Or simulation of functional activities like car transfers. A lot of times in the hospital, before someone leaves, we simulate a car transfer. We have a fake car, and we do a simulated car transfer just to make sure that person can successfully get in and out of their car when they leave the hospital. So that's a good example of therapeutic activities. It may also include bed mobility and transfer training. So it involves the use of a functional activity to restore functional performance in a progressive manner. So I always say with bed mobility and transfers, the main difference is it has to be a skilled intervention. So the PTA is not transferring the patient, they are teaching the patient to get better at transferring themselves. That's what makes it a skilled intervention versus I'm just going to move you from one place to another. Same thing with bed mobility. I'm not just going to roll you over onto your side. I'm going to work with you to improve your ability to roll over onto one side by yourself. So that's the difference between skilled therapy and just moving a patient around. So self-care and home management training. Some insurance companies reimburse for this and some do not. So you should know before you charge this code whether or not your patient is going to get charged for it or their insurance company is going to pay for it. So really it involves improving someone's activities of daily living, compensatory training. A lot of the things OTs do, like meal preparation, use of instructing them how to use adaptive equipment. This is probably more OT related than PT related, but if you're teaching someone pain management techniques or how to use home modalities for pain management, that could be self-care or home training. So bathing, grooming, dressing, personal hygiene, basic household chores, cooking, using appliances, and medication management. So a lot of those are kind of OT related. So there's where the OT and PT crossover. But it is possible that we could be doing this. The other thing is teaching caregivers how to help the patient. So that could be a self-care home management training code as well. probably not as common. And in our classes that we're doing in the program, we're probably not charging that code. I'll just tell you that. Wheelchair management is another one that we're probably not charging all that often. Assessment, fitting, and training. It's a 15-minute code. It includes wheelchair evaluation performed by a PT or OT, so PTAs don't usually do that. But testing the patient's ability with various chair functions, like can they propel it themselves using their arms? Can they propel it themselves using their legs? Also adjusting or determining types of seat cushions, back support, head and neck support, arm rest, leg rest, etc. That's wheelchair management. And training the patient and their family in use of the wheelchair. So depending on the setting that you work in, you may or may not encounter using this code and the type of patients in your caseload. So commonly used ones that we're going to use a lot in the program are 97110 therapeutic exercises, 97112 neuromuscular re-ed. I always say the one that's not on this list, well, gait training's on there. I always say like one Therax, one neuro, one gait. That's a that's a neuro patient charge for sure. You had a 45-minute appointment, you did one Therax, one neuro, one gait. But most of the modality treatments that we're going to do in PTA 111, like ultrasound, electrical stim, manual therapy, like soft tissue mobilization, those are the ones we're going to use commonly in that class. Electrical stimulation. There are two, group therapy is untimed, and there are two modalities treatment that are untimed. If you put electrodes on someone, give them a bell, and walk out of the room, that's unattended electrical stim, and that is an untimed charge. So it doesn't matter if they're there for 10 minutes or an hour, you charge 1 unit. Mechanical traction is another one that's untimed. So that's just the way it is. That's the way it's defined by the AMA. So a lot of times, because I work with a neuro caseload, a lot of times I'm doing electrical stim for neuromuscular reeducation. So I don't charge it under electrical stim. I charge it under neuromuscular reeducation for neuromuscular facilitation, kinesthetic sense, proprioception, lots of different reasons to use that. So that having been said, billing is an art rather than a science. Physical therapy billing can change depending on what the purpose of your treatment is. So a lot of physical, and this is a quote from a billing specialist, most physical therapy practices underbill and use the wrong codes and therefore get underpaid. It's common seeing therapists spend over an hour with the patient and only bill for 2 to 3 units of care. So if a unit of care is 15 minutes and you're spending an hour with the patient, you need to bill for 4 units of care, meaning you have to give them 4 units of skilled therapy. So if you're not doing that, they're not getting their money's worth and you're not getting paid enough. So so it's really important to make sure that you're doing skilled therapy the whole time and you're billing appropriately for it. So any one thing you do could be billed under different codes depending on the reason you have for doing it. So if you recall, if you listen to the SOAP note lecture and you recall in the treatment section, I said you need to say what you did and why you did it. So the why you did it is what determines your CPT code. So this is an example of showing a patient how to perform an oblique abdominal sit-up. Okay, we've all done those. Maybe you did it earlier today. I didn't, I did it yesterday. Anyway, if you're teaching a patient this exercise for the purpose of increasing their strength and flexibility, which I believe is the reason I did it yesterday, you can bill CPT code 97110 therapeutic exercise. Easy squeezy, right? So if it's in the plan of care, if therapeutic exercise is in the plan of care and increasing the patient's strength and flexibility, bam, you got it. Okay, however, if you're showing the patient the exercise for the purpose of facilitating dissociative movement between lumbar and thoracic segments, thereby improving proprioception, you can bill the code 97112 neuromuscular reeducation. Or if you're doing the exercise for the reason of improving axial mobility to decrease rigidity because they have Parkinson's disease, 97112. It's neuromuscular reeducation. You're not doing it just to get stronger and more flexible. You're doing it to re-educate the nervous system. And that's why we're charging neuromuscular reeducation. If you're showing the patient the exercise for the purpose of improving the functional performance of getting out of bed, because you need to do that, get out of bed, you can bill 97530 therapeutic activities, because that's why you're doing it. So there are a variety of ways you can bill for the procedure, and depending on your intent, there's the proper CPT code to use. But you have to make sure to justify your treatment intentions and document them properly in order to avoid problems later. So if in your treatment section you said, instructed patient in abdominal oblique sit-up to improve functional performance in getting out of bed, that's a nice statement right there. You are going to charge 97530 therapeutic activities. If you said instructed patient in oblique abdominal sit-up to improve upper and lower trunk dissociative movement to decrease axial rigidity, sure, 97112. So document what you did, why you did it, and that should tell you which code you should use. It sounds easy when you say it that way, doesn't it? Maybe not as easy in real life. So in terms of billing units, so I talked about like you have someone for an hour, you should bill 4 units. So really a basic unit is 15 minutes. So by definition, 1 unit is 15 minutes. However, there are ranges of minutes that qualify as 15. So you can think of it as 15 plus or minus certain things. So 1 unit is anything equal to or greater than 8 minutes or less than 23 minutes. So if you do 22 minutes of something, you cannot charge two units for it. You can only charge 1. If you do it for 1 more minute, you can charge 2, because 2 units is greater than or equal to 23 minutes and less than 38 minutes. So if you have 45-minute appointments in your clinic, like the clinic I work in right now has 45-minute appointments, you better be doing skilled therapy for at least 38 of those 45 minutes if you're going to bill 3 units, because 3 units is greater than or equal to 38 minutes and less than 53 minutes. If you have hour-long appointments, you better be doing at least 53 minutes of skilled therapy and up to less than 68. 5 units, 68 to 83. It's rare that you're going to be billing more than 4 or 5 units, but in certain settings you might. So if you have 30-minute appointments, you better be doing skilled therapy for at least 23 minutes so you can bill 2 units. A lot of times in your practicals and in class, you'll have a 25-minute treatment. That means you're doing something you can bill 2 units for. So if you start thinking in units, start thinking in 15-minute increments, that helps you come up with this. So, okay, I'm just going to leave it right there for the 8-minute rule. So we'll just keep talking about this, and we'll keep. But when you're starting to write down how many minutes you did something, bear this in mind. If you did something between 8 and 22 minutes, it's 1 unit. If you did less than 8 minutes of something, you cannot bill for it. So there's that too. So there's sometimes when I'm doing something in conjunction with the treatment, and I'm certainly documenting, of course, but it takes less than 5 minutes to do, of course I'm not going to charge for that. If I put kinesio tape on someone and it just takes a couple minutes, I'm not charging for that. I'm documenting it, but I'm not charging for it. Crazy, right? So for time-based codes, you must provide direct treatment for at least 8 minutes in order to receive reimbursement from insurance, including Medicare. When the insurance company is calculating the number of billable units for a particular date of service, they add up the total minutes of skilled one-on-one therapy and they divide the total by 15. So if 8 or more minutes are left over, then you can bill for 1 more unit. If 7 or fewer minutes remain, then you can't bill for an additional unit. So if I had 40 minutes of skilled one-on-one therapy and I divide that by 15, I get 2 and so 2 15-minute units, that's 30 minutes, and then I get 10 more minutes. So that 10 minutes, I can bill for that 3rd unit. Does that make sense? So that's kind of how they figure out the 8-minute rule. So just think of things in chunks of 15 minutes, but think of the 15 as plus or minus a few. And then we'll keep talking about this and hopefully it'll start making sense. So this is the references. That was the CPT changes in 2018. That was kind of the most up-to-date one. And if you ever want to read some really exciting documentation, you can get it from the American Medical Association. You can even subscribe to that.